Hey y'all, it's Julie the nursing tutor. You want to talk about your pituitary glands and some NCLEX questions? Okay, calm down. Here we go. The anterior pituitary gland secretes tropic hormones in response to which hormones from the hypothalamus? Releasing hormones, target tissue hormones, growth hormones, or demand hormones? And you can pause me and read it yourself. You got your answer? A. Releasing hormones. The anterior pituitary secretes because of releasing hormones. Which hormones are secreted by the posterior pituitary gland? Select them all. Testosterone, oxytocin, growth hormone, antidiuretic hormone, cortisol, or prolactin. You got your answer? Look, it's oxytocin and antidiuretic. And the way I remember it, posterior pituitary has 2 P's. And it only has 2 hormones. And they both start with vowels. Oxytocin and ADH. Yeah. Does your brain work like mine? I don't know. A patient is suspected of having a pituitary tumor. Which radiographic test aids in determining the diagnosis? Skull x-rays, MRI with contrast, angiography, or an ultrasound? You got your final answer? Yeah, MRI. Imagine the MRI with contrast. Because your pituitary gland's all up in the middle of your head, so it's going to be a process getting there. A malfunctioning posterior pituitary gland can result in which disorders if it's jacking up? Select them all. Hypothyroidism, altered sexual function, diabetes insipidus, growth retardation, syndrome of inappropriate antidiuretic hormone, or virilization. Sound like it need antibiotics. You know, they say she got virilization. Okay, you got your answers? Yeah, diabetes insipidus and soggy Sid. I've got a video with mnemonics. I would encourage you to go watch that and then maybe come back and do these. You know, repetition is the mother of learning. Here we go. A malfunctioning anterior pituitary gland can result in which disorders? Select them all. Pituitary hypofunction, pituitary hyperfunction, diabetes insipidus, hypothyroidism, osteoporosis, or SIADH. If they had a gun to your head and said you had to answer it, what would you put? Now, we just saw these 2 right here. That one and that one was over there on the posterior. So we can throw them out. You got your answer? A, B, D, and E. Okay. Here we go. The assessment finding of a male patient with an anterior pituitary tumor includes reports of changes in his secondary sex characteristics, such as episodes of impotence and decreased libido. The nurse explains to the patient that these findings are a result of overproduction of which hormone? Gonadotropin inhibiting prolactin, thyroid hormone inhibiting prolactin, prolactin inhibiting secretion of gonadotropins, or steroids inhibiting production of your sex hormones. And look, if you're going to get it wrong, this is where you want to get it wrong. Because you're sure going to know after this. 3, 2, 1. C. Prolactin inhibiting secretions of gonadotropins. Okay, I know you want more, but look, write that down and look in your textbook, or either we'll discuss it on another video. When reviewing the medication record for a patient being treated for a PRL, that's prolactin, secreting tumor, The nurse is most likely to note the use of which medication? Dopamine agonist, antidiuretic hormone, corticosteroids, or growth hormone? You guys are answering? A, dopamine agonist. I should have looked that up before I did this, but write it down and look it up. This will help you. It'll be a scavenger hunt. A 30-year-old female patient is we don't use that anymore, my bad. A patient diagnosed with an anterior pituitary tumor can have symptoms of acromegaly. The symptoms are a result of overproduction of which hormone? I ain't going to tell you nothing yet. ACTH, prolactin, gonadotropins, or growth hormone? Yeah, it's growth hormone. Acromegaly. Acro means your exterior arm, hands, and feet. Megaly means them suckers is big. And the reason they get acromegaly is because this tumor happens after the epiphyseal discs in their bones have already calcified and become bone. Those people that get an anterior pituitary tumor that secretes growth hormone are going to get acromegaly. If they had if their epiphyseal discs in their bones had not yet calcified, then they would get giantism and their bones would grow big until, they was calcified. But a lot of times these people, they'll have a jutted out jaw and their forehead will get thick. Anyway, we're going to pray for them. All right. The nurse is performing an assessment of an adult patient with new onset acromegaly. What does the nurse expect to find? Extremely long arms and legs, thickened lips, changes in the menses with infertility, or rough and extremely dry skin. Thickening of the lips. Now, I know I didn't say that a while ago, but now you know. Look up acromegaly and look at the picture they got in there. When analyzing laboratory values, the nurse expects to find which value has a direct result of the overproduction of growth hormone. Hyperglycemia, hyperphosphatemia, hypocalcemia, or hypercalcemia with the overproduction of growth hormone. Okay. Hyperglycemia. Lock it in your frontal lobe. Okay, in caring for a patient with hyperpituitarism, which symptoms does the nurse expect the patient to report? Select them all. If her pituitary is hyper, joint pain, visual disturbances, changes in menstruation, increased libido, a headache, or fatigue. Your pituitary gland. You may want to pause it and pray about it, but here we go. 3, 2, 1. A, B, C, E, and F. It's certainly not going to increase your libido, or people will be out trying to get hyperpituitarism, but joint pain because of growth hormone, visual changes because your pituitary is right up in the middle of your head by your optic nerve, changes in your menses because it has luteinizing hormone, follicle stimulating hormone, a headache because it's up in the middle of your head, and fatigue just because dog. A deficiency of which anterior pituitary hormone is considered life-threatening? Select them all. Growth hormone, melanocyte-stimulating hormone, prolactin, TSH, ACTH, or luteinizing hormone. Thyroid-stimulating and ACTH. Those are life-threatening if they're jacked up. a deficiency of them if they're low. I mean, and we'll talk about it more. Which statement about the etiology of hypopituitarism are correct? Select them all. Dysfunction can result from radiation treatment to the head or brain. It can result from infection or a brain tumor. Infarction following systemic shock can result in hypopituitarism. Severe malfunction and body fat depletion can depress pituitary gland function. There is always an underlying cause of hypopituitarism, and pituitary tumors are the most common cause of hypopituitarism. You're going to hear me on your test. Got your answers? Pause it. And then 3, 2, 1. A, B, C, and D. Radiation to your head or your brain. You got an infection or a brain tumor. Infarction from systemic shock. And severe malnutrition and body fat depletion. We're going to pray for them. Which statement about hormone replacement therapy for hypopituitarism is correct? Once manifestations of hypofunction are corrected, treatment is no longer needed. The most effective route of androgen replacement is the oral route. Testosterone replacement therapy is contraindicated in men with prostate cancer, or clomiphene citrate is used to suppress ovulation in women. C. Testosterone replacement is contraindicated in men with prostate cancer because we got to help clear that up. A female patient has a prescribed hormone replacement therapy. What does the nurse instruct the patient to do regarding this therapy? Select them all. Well, I done told you right there, but look, they expect you to know to tell her this. So listen. We're going to say what's right. Avoid smoking because of the increased risk for cancer, cardiovascular complications. When you're on hormones, you know, she done, her ovaries done fossilized and she's in menopause, which is not for sissies, I must say. If she gets on hormone replacement, smoking can, along with that, will jack you up, potentially. Take measures to reduce the risk of hypertension and thrombosis. Regular follow-up visits with your healthcare provider are essential if you're on hormone replacement therapy. I'm not even going to read the other ones because it's a lie from the pits of hell. A patient requires 100 grams of oral glucose for suppression testing of growth hormone levels. For suppression testing, and growth hormone levels are measured serially, like every 2 hours, for 120 minutes. The result of the suppression testing are abnormal, and the nurse assesses for the signs and symptoms of which endocrine disorder. Adrenal insufficiency, diabetes insipidus, hyperpituitarism, or hypothyroidism. You got your final answer? Hyperpituitarism. I know you're going, what does that mean? I'm just giving you a guided tour on what to look up in your book. A patient is recovering from a transsphenoid. That means they went up your nose. Hypophysectomy. A hypophysis, that's a smoking dope name for a pituitary gland. They'll have the adenohypophysis, which is the anterior pituitary, and the neurohypophysis, which is the posterior pituitary, because the posterior pituitary gets its stimulation from a nerve impulse, but the anterior pituitary gets its stimulation from releasing hormones that come from the hypothalamus down the infundibulum. I like that word. Anyway, I done told you the answer on this. Dookie fart. Well, look, they expect you to know this. Transphenoid. They going up your nose to the middle of your brain. Father God. What post-op nursing interventions apply? Encouraging the patient to perform deep breathing, probably because we put her to sleep. So all post-op people need to turn, cough, and deep breathe. It's the law. Strict monitoring of oral balance. Hourly neuro checks for 24 hours because we have been up her nose in the middle of her brain. And instructing the patient to alert the nurse regarding a post-nasal drip. After we done been up her nose in her brain, because if they have a clear fluid that is a post-nasal drip down the back of their throat or dripping out of their nose, it may be cerebrospinal fluid. I mean, what are you going to do? Okay, following a complete hypophysectomy, the patient requires instruction on hormone replacement for which hormones. We done took the sucker out of there. So is it going to be cortisol, thyroid, gonadal, aldosterone, prolactin, or vasopressin? Remember, vasopressin is man-made antidiuretic hormone. You got your answer? If you don't, open a clean page in your frontal lobe and write this down. Cortisol, thyroid, gonadal, yeah, and vasopressin. Okay. After a hypophysectomy, a focused assessment and monitoring by the nurse include which factors? Select them all. Cognitive and mental status, maintaining bed rest with a bedside commode, possible leakage of cerebrospinal fluid, 24-hour intake of fluid and urine output, a 24-hour diet recall, headache or visual disturbances. So after a hypophysectomy, when you go in there, your focused assessment, and you're going to be monitoring which of those. You got your answer? 3, 2, 1. A, C, D, and F. Cognition and mental status. A possible leak of cerebrospinal fluid. Yeah, man. I mean, that would be one of those dookie fart situations. So in your book, I would look up, after a hypophysectomy, if there is a cerebrospinal fluid leak, what do they expect me to know to do? And I'd be able to list it for them for a bonus on a blank sheet of paper. 24-hour intake of fluid and urine, headache, and visual disturbances. Okay, I hope that's perfectly clear. The nurse providing care for a patient who had a hypophysectomy by the minimally invasive endoscopic transnasal approach. How is the care different for this patient as opposed to a patient with a transphenoid hypophysectomy? The patient is encouraged to cough and deep breathe to decrease pulmonary complications. The patient does not have nasal packing of a mustache dressing. The patient should be taught to floss and rinse their mouth frequently. The patient must be taught that hormone replacement is lifelong. B, the patient does not have nasal packing of a mustache dressing when they do the minimally invasive endoscopic transnasal approach. They don't have packing. All right. While Caring for a post-op patient following a transphenoid hypophycectomy, the nurse observes nasal drainage that is clear with yellow color around the edges. This halo sign is indicative of which condition? I mean, if you don't know it, front lobe material right here. Worsening neurologic status of the pages. Drainage of CSF from the patient's nose. Onset of post-op infection or an expected finding following this surgery. Yeah, that's drainage. You see what they said? Clear with a yellow color at the edge. If you put it on a piece of gauze, a drop of it, it'll be clear, but there'll be a halo around it. And your butt will be like, puckered. Because, I mean, if CSF can get out, imagine what could get in, all I'm saying. A patient with a hypophycectomy can postoperatively experience transient diabetes insipidus. Which manifestation alerts the nurse to this problem? Urine output is much greater than intake. A change in mental status indicating confusion. Laboratory results indicating hyponatremia or non-pitting edema of lower extremities. Diabetes insipidus, they need a sip. We got to keep giving them a sip because they don't make enough anti-diuretic hormone. Diuretics make you pee. Anti-diuretics make you not pee. Diabetes insipidus doesn't have enough of that. You got your thing? Yeah. He's pissing it all out. My God. He can't hold on to it. Nary a drop. So we're going to pray for him. The action of anti-diuretic hormone influences normal kidney function by stimulating which mechanism? The glomerulus to control filtration, proximal nephron tubule to reabsorb water, the distal nephron tubule to collecting duct to reabsorb water, or constriction of the glomerular capillaries to prevent loss of protein in urine. Okay, I'm sure you could throw these two out. Let's see. This was in an RN med-surg study guide. So, it's just good to know. Makes you a better nurse. What is the disorder that results from a deficiency of vasopressin, ADH, from the posterior pituitary? I just told you a second. Diabetes insipidus. They don't have enough anti-diuretic hormone. So everything they drink goes through them. So diabetes insipidus, you need to give them a sip. We're giving them a sip all the time. What statement about diabetes insipidus are accurate? It is caused by ADH deficiency. By golly, you're going to know that. It's characterized by decreased urination. Urinary output is greater than 4 liters in 24 hours. Is the first diagnostic indication. Urine output of greater than 4 liters, in 24 hours is the first diagnostic indication. The water loss increases plasma osmolarity. Nephrogenic diabetes insipidus can be caused by lithium. Increased thirst is a mechanism of the body in attempt to maintaining fluid balance. Pause it and read it again because I know I told y'all. But anyway, 3, 2, 1. Yeah, it is a deficiency. And the urine output, it's just a vulgar amount. And the water loss increases plasma osmolarity. And increased thirst is a mechanism God gave us to try to help us. Okay. What does the nurse instruct patients with permanent diabetes insipidus to do? Select it all. Continue your vasopressin therapy until your symptoms disappear. Monitor for recurrence of polydipsia and polyuria. That's the diabetes of diabetes insipidus. They don't have polyphagia because that's caused by the sugar or the lack of sugar in the cells. But polydipsia and polyuria are in diabetes insipidus. Monitor and record the weight daily. Check the urine-specific gravity 3 times a week. Wear a medical alert bracelet. Urge the patient to drink fluids in a amount equal to their urine output. This is what they expect you to know to tell these poor people going home or wherever they're going. B, C, E, and F. Polydipsia, they got a monitor for it. And look, continue vasopressin until your symptoms disappear. They're not going to disappear. Ethel, shh, don't let her see that part. You are going to record their daily weight because the best indication of a patient's fluid status is a daily weight. That'll be on your NCLEX. Write that down somewhere. Everybody that's got something should wear a medical alert bracelet. And then, if you pee 500, drink 500. Okay. A hospitalized patient is prescribed desmopressin. Don't that kind of look like cousin to vasopressin? Because they are. But this is the metered dose spray as a replacement hormone for vasopressin. Desmopressin. If you just got pressin in it, that's what it is. And it'll probably make your vessels press in too. Anyway. Which is an indication for another dose? Excessive urination, specific gravity of 1.003, dark concentrated urine, edema in your legs, decreased urination, or shortness of breath. Hospitalized patient, and he's getting ADH, so he's got to have diabetes insipidus. What you think? You got your answer? Right, A and B. We saved them. I know we did. Because look, dark urine, edema in your legs, decreased urination, shortness of breath. That's probably soggy Sid. Yeah. The nurse is caring for these people with diabetes insipidus. What's the priority goal of the collaborative treatment? Collect the water metabolism problem, control their blood sugar and blood pH, measure urine output, specific gravity, and osmolality hourly, or monitor closely for respiratory distress. Diabetes insipidus. Correct the water metabolism problem. Because, when you pee it out, you're metabolizing it, so there you go. Which medication is used to treat diabetes insipidus? Desmopressin. It should have been, I know y'all losing your mind right there. Vasopressin is too. I'm going to move on look, just don't send ugly fan mail. Look in your book. Look in your book and then make a video and post it for us all to see. Which patient's history puts him or her at risk for developing SIADH? 27-year-old on high dose of steroids. 47-year-old hospitalized adult patient with acute renal failure. 58-year-old with small cell lung cancer. Or an older adult with a history of a stroke within the last year. You got your answer? Small cell lung cancer. This has been a question on people's NCLEX. A cause of SIADH is cancer, specifically lung cancer. So somewhere inside yourself, get a Sharpie marker and write it on your frontal lobe. Which statement about the pathophysiology of SIADH is correct? ADH secretion is inhibited in the presence of low plasma osmolality. Water retention results in dilutional hypernatremia and expanded extracellular volume. The glomerulus is unable to increase its filtration rate to reduce the excess plasma, or renin and aldosterone are released to help decrease the loss of urinary sodium. So you can only answer one. What you think? SI-88, soggy Sid. If that's all you knew, you could answer this. Water retention. He's so soggy. If y'all hadn't watched that Nursing Made Insanely Easy by Sylvia Rayfield, this was back in the 80s that she had a NCLEX prep class or whatever, and she was phenomenal. Her resources are just epic. The effect of increased ADH in the blood results in which effect on the kidney? ADH, diuretics make you pee, antidiuretics make you not pee. Urine concentration tends to decrease. Glomerular filtration tends to decrease. Tubular reabsorption of water increases. Tubular reabsorption of sodium increases. You got your answer? Tubular reabsorption of water. ADH tells the kidneys to save water. Aldosterone is a mineral corticoid, and it tells the kidneys save sodium, and water follows that. I got adrenal glands coming next with stuff like this. In SIADH, as a result of water retention from excess ADH, which lab value does the nurse expect to find? Select them all. SIADH. He's holding it. Increased sodium in the urine, elevated serum sodium level, increased urine-specific gravity, decreased serum osmolality, decreased urine-specific gravity, or decreased serum sodium. Okay, think about it. He's holding all his water on board, so everything's going to look like it's diluted. And whatever he's peeing, he ain't peeing much, but what he's peeing's thick. Dadgummit thick. Got your answer? 3, 2, 1. Increased sodium in the urine, increased urine-specific gravity because what he's peeing is thick, decreased serum osmolality because it's holding all the water, everything's diluted, and decreased serum in the blood sodium level because it's diluted. Which nursing intervention is the priority for a patient with SIADH? Restrict fluid intake, monitor neurologic status at least every 2 hours. Offer ice chips frequently to ease discomfort of the dry mouth. Monitor urine tests for decreased sodium level and low specific gravity. Got your answer? Yeah, restrict fluid intake. That sucks for him. But, I mean, until we get you handled, you know, hopefully he don't have respiratory or cardiac problems. We're going to pray for him, though. Which type of IV fluid does the nurse use to treat a patient with SIADH when the serum sodium level is very low? I would let the physician choose it. C, very low, 3%. Yeah, I imagine you'd be giving that. I'm not going to say anything because we'll have everybody on here saying, I mean, there's no absolutes in medicine, and there's always something that'll make it go different. But anyway, I'm moving on. In addition to IV fluids, a patient with SIADH is on fluid restriction as low as 500 to 600 milliliters in 24 hours. Which serum and urine result demonstrates effectiveness of that treatment? If we're holding it down. For SIADH, decreased urine-specific gravity, decreased serum sodium, increased urine output, increased urine-specific gravity, we don't want that, increased serum sodium, decreased urine output. Pause it and pick your letters. 3, 2, 1. ACE, decreased urine-specific gravity because what he was pissing was thick. Now it's not so thick. Increase urine output because he wasn't peeing much, and so he needs to pee more. And increase serum sodium because it was low. It was just so diluted with all the water he was holding. I hope that this is helping. Which medications are used in SIADH to promote water excretion without causing sodium loss? Select them all. I'm going to do it. A and D. That one and that one. Check your book. It should have a list of medications you need to know. A patient is undergoing a fluid... We already did that one. The fluid Okay, a patient's undergoing a fluid deprivation test. The nurse correctly recognizes this test is used to assess for which condition. And it's diabetes insipidus. Okay. The nursing instructor lectures on the hormones of the anterior pituitary secretes, including growth hormone, thyroid stimulating hormone, antidiuretic hormone, follicle stimulating, luteinizing. Which ones come from the anterior pituitary? It's more than just these. I would be able to list them on a blank piece of paper if she wanted me to. A, B, D, and E. A, B, antidiuretic hormone starts with the A, remember? That and oxytocin are in the posterior pituitary. Okay. A patient who had a hypophysectomy 3 days ago begins to have 3,000 milliliters of urine output every shift and complains of thirst and dry mouth. The nurse interprets these signs as a possible what? Overreaction to diuretics, diabetes insipidus, diabetes mellitus, glucose intolerance. You know. Yeah, diabetes insipidus. It's a complication of a hypophysectomy. The posterior lobe of the pituitary gland controls urinary output. Where this portion of the pituitary is removed, when this portion of the pituitary is removed or damaged, there's no secretion of antidiuretic hormone to stop excessive urine output. I mean, dude, keep fart. That would suck. Okay. The student nurse is aware that the patient has central diabetic insipidus because the disease was the result of the patient having what? Central diabetes insipidus. They have neuro something. But anyway, brain surgery or removal of a tumor, a kidney disorder, habitually consuming excessive amounts of water, or a thyroid disorder. Look, it's A, central, because they was up in the middle of his head, in the central part of his head, central diabetes insipidus, specifically that kind, is caused by insult to the pituitary or brain injury or tumor and invasive surgery. The severe dehydration associated with diabetes insipidus can lead to the serious electrolyte imbalance of hypercalcemia, hypernatremia, hypocalcemia, or hyperkalemia. Severe dehydration associated with diabetes insipidus. You got your answer? Hypernatremia. The loss of potassium in large amounts, in large volume of urine depletes the compensatory mechanism and hypernatremia results. Okay, so go in your book at diabetes insipidus and pay attention to the electrolyte portion. The effects of a benign pituitary adenoma include a benign pituitary adenoma, gigantism in children, acromegaly in adults, muscle weakness, excessive hair growth, or joint pain. Select all that apply. You got your answer? A, B, C, and E. There is no hirsutism with which is excessive hair growth. That's what that word means. Hirsutism means excessive hair growth. Postoperative hypophysectomy instructions that will be given to a patient before surgery will include the presence of a drip pad under your nose, postponing brushing your teeth, presence of nasal packing for several days, the need to cough and deep breathe, avoid bending over. That's what they expect you to tell these people. And we're giving them post-operative instructions before surgery because they're going to be loaded as a goat when they come back from surgery. So it's A, B, C, and E. They're going to be a drip pad under your nose so we can see if you got cerebrospinal fluid. And if you brush your teeth, you're going to jack the spot we popped a hole in you. They'll have nasal packing. And don't bend over because that increases the pressure in your head. And the patient should not cough, sneeze, or blow their nose because that could cause the cerebrospinal fluid in your brain to come out. Dear God. Planning care for a patient with diabetes insipidus will include, select all of them. Maintaining fluid therapy, conserving energy, supporting dietary choices to reduce diarrhea, assessing for bradycardia, or encouraging exercise to reduce their weight. Maintaining fluid therapy, conserving energy, and assessing them for bradycardia because they need a SIP. Diabetes insipidus needs a SIP. They're constipated. They're not diarrhea and frail from weight loss. God love them. A tumor of the pituitary has caused SIADH. The nurse plans interventions for assisting with activities of daily living because of weakness, recording accurate urinary output because of oliguria, weighing daily to assess edema, assessing for changes in the LOC because of confusion and seizures, and assessing their stools for occult blood. Soggy Sid, think about him standing there. You got your answers? Yeah. Activities of daily living because they're weak. Keeping accurate because Soggy Sid, remember his pee is thick. He's holding it all on board. And weigh him daily because that's the best indicator of fluid status. And look, you get so hyponatremic because it's dilutional, you're going to get the signs and symptoms of hyponatremia. Okay, here we go. I didn't realize this was at the end. The effects of a benign pituitary adenoma, it secretes growth hormone. And it leads to continued growth of bones and soft tissue. This is it also antagonizes the effect of hormone insulin, resulting in increase in blood glucose and glucose intolerance. There is increased pressure within the optic chiasm, which, if not relieved, will destroy the optic nerve and produce blindness when they got a dad-blame tumor in the middle of their head. We got to help them. Okay. And the treatment, all this is saying is he may choose to do it conservatively with hormone therapy. If it continues to grow, they may need to treat it surgically. Okay. There are 3 primary mechanisms of diabetes insipidus. Central. It's associated with brain tumors and head injuries, neurosurgery, or central nervous system infections. Central. But look at this. Nephrogenic diabetes insipidus is caused by drug therapy, lithium, it just burn your kidneys up, or kidney disease, nephrogenic diabetes insipidus. Help them, God. And then dipsogenic, that sounds like an insult, diabetes insipidus is caused by excessive water intake, and it's sometimes associated with schizophrenia. Dipsogenic, shut up. Nurse management of diabetes insipidus focuses on, this is what they expect you to know, early detection, maintenance of fluid and electrolyte balance, and patient education. And we know that, oh my goodness. A patient with a deficiency of which hormone will exhibit symptoms of diabetes insipidus? You know it. Insulin, glucagon, estrogen, or ADH? You know, diabetes insipidus. Look, pause it. This is going to end up being a fluid deprivation test is used to diagnose diabetes insipidus. The test is performed while the patient's NPO. The patient is NPO, hourly urine output, specific gravity and osmolality are measured, along with body weight and vital signs. Vasopressin is given subcutaneously. Hourly measurements are continue for several hours. Dookie fart. Okay, a patient with acromegaly will most likely exhibit which symptoms? Bone pain, frequent infections, fatigue, or weight loss? You know. Yeah, because his bones grow. A patient has diabetes insipidus. The nurse should anticipate giving which... We already did that one. We got to give them... Look, see that one? There's another one. Putrescin. We done see desmopressin, vasopressin. Here's putrescin. You're looking for the tressin. Pause it and read all that. The nurse is caring for a patient who's been experiencing infertility. Inadequate levels of luteinizing hormone have been identified. The patient correctly verbalize what outcome of the reduced hormone level. Luteinizing hormone works to stimulate ovulation and the production of progesterone. The swelling I experienced during my menstrual cycle is a result of this hormone. The hormone is responsible for the irregularity of my menstrual cycles, or the hormone is responsible for maintaining my secondary sex characteristics. If you're an OB, you got to know this. Luteinizing hormone causes ovulation. Oh, I'm not going to take up time to tell you this, but there'll be another one, me talking about an ovary. A patient with a pituitary tumor will most likely exhibit altered visual acuity, frequent diarrhea, alterations in glucose, or urticaria, which is itching. What you think? A, because of the location in the middle of their skull, adjacent to their optic nerve and their brain, pressure on this area can cause an increase in intracranial pressure. As a pituitary tumor enlarges, intracranial pressure continues to increase. Common symptoms of increased intracranial pressure. My goodness. This will be on your NCLEX. Nausea, headache, vomiting, and decreased visual acuity. I hope y'all are watching all the way to the end. Okay, I'm going to stop it. I'm going to show you this one, then I'm going to stop it because it's too long. Levels of which hormone will provide information about the functioning of the pituitary gland? Luteinizing hormone, follicle stimulating, growth hormone, thyroid hormone, or prolactin. If we get levels of those, which one of those will tell us how the pituitary gland's doing? Every single one of them. Okay, I hope y'all helped. I know I went on and on, but hopefully you made notes on your frontal lobe. Have a good evening.